should be considering, what type of hypertension it is. These are classification. So this is question is about this. Like, do you know primary, secondary causes? So, and how will you rule out in primary, secondary causes of hypertension? Pretty much, that's the theme. So, what are the causes of primary, secondary hypertension? Let's start with that. What are the differential, guys? What is primary? What is secondary hypertension? And what are the risk factors can cause? How will you evaluate? One, you can't have a side. You can't be giving me silent therapy. When I'm angry with my boyfriend, I give him silent therapy. You don't give me silent therapy. I'm ready. Adrenal, what adrenal thing? What were you thinking of adrenal? What is the common condition in adrenal? Yes, renal, secondary. Divided into two portions, primary and secondary. Thyroid, yes, thyroid, pheochromocytoma, pheochromocytoma. We ruled out with that. Fanconi syndrome, yes. And ladies, ladies and gentlemen, ladies, Cushing syndrome is very good. I was thinking nobody will think about Cushing. Cushing syndrome. What is the primary cause as well? Drug is the primary cause. Why are we concerned about the hypertension so much? Is it because it's common in Australia and AMC loves it? Okay. And ladies, you don't have an options. Ladies, I'm just to talk about hypertension. What are the risk factors can cause? These are the causes which can give you primary and secondary hypertension. What are the risk factor can cause hypertension? There is some mnemonic called trackpad or something. Um, you need to apply that. Having said that, I don't need to know still, and not always I follow the mnemonic. Okay, Shinomoto, yes. And lifestyle. So risk factors we will be looking for what you call alcohol, high salt intake, because we will be giving this guy guideline that mate we need to stop things. Okay, we have to be talking about that. Okay, let's go on. So all good. Everyone gave me a good diagnosis. So what we need to be thinking, dividing these questions into very good. So yeah, everyone aware about that. I have a lot of patients back home here, smoking, yeah, family field, which is good. So we have a lot of differential. So what we need to do, we need to be actually assessing in the history um, signs of liver failure, also like causes started with in the family. So heart failure, ischemic heart disease, chest pain, shortness of breath. It won't be starting like right away that you have a high blood pressure. So he has been identified high blood pressure, but you need to ask, is that first you start with the signs of complications. Okay. Are you experiencing any chest pain? Have you experienced any chest pain, shortness of breath, any heart racing, any lagging edema? We have been talking about congestive heart failure. And have you ever difficulty in walking? Peripheral vascular diseases. Okay, remember peripheral vascular disease, we do the blood pressure from all over the body. So what you're doing identifying all the causes of peripheral vascular disease. Are you having regular headache? Because we are looking at the signs of complications. So it means if we have been look, guys, remember one thing. This is I've noticed from AMC. When they're saying we diagnosed it already, and now you're seeing the patient, let's say even after 3 to 1, when you diagnose or found something, they're kind of giving a hint, we have found something. Always ask signs of complication first. Always ask. From John, I met you that day. From that day to now, have you developed da 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 da? So these are the things which we're asking. Complications. So everyone knows. Have you had any heart racing, chest pain, irregular headaches? Have you experiencing impaired vision? Which means I also gave you the grade of hypertensive retinopathy. Extensively will be coming in a, someone having chronic hypertension and being missed. So we'll have a hypertensive retinopathy. You know that, right? That AV nipple. So we will see the hypertensive retinopathy in the people. Any line pain, hematuria, dysuria. Why? That can also happen. There's any bleeding, any renal failure. Okay. Now, secondary hypertension questions are important. Any pallor, sweating, which suggests of pheochromocytoma. How's the appetite and change in appetite? That usually they gain the weight and there's sudden tumor. Pheochromocytoma is a tumor of adrenal glands. You need to be knowing. Now again, Cushing's syndrome. So you won't be going all the causes of it, like to find out, but you will be asking the few ones, acne. And what about the renal problem in the past? Like, has it been? You should be remember chronic renal failure, any renal disease. We have a necrosis, we have a polycystic kidney disease congenitally, we have a ischemic. So any renal problem has to, any kidney problem you have been diagnosed. Those people have this congenital anomaly, renal artery stenosis. They also have it. We have a case in AMC for renal artery stenosis. It hasn't come yet so far, but it is like you do need to rule out. If you do not actually rule out renal artery stenosis, is again a problem. That can also cause hypertension. Okay. And have you had in the past any ischemic heart problem? Any problems with your lipids? Have you checked your lipids? Have you had suffer from anybody had suffer from high blood pressure, stroke, any heart condition, and they die because of that? Other risk cardiovascular risk factors you need to rule out, such as alcohol and smoking, which we spoke about. And then occupation. Occupation, what do you do for a living? Lifestyles, sedentary lifestyle, like someone like me nowadays, I'm actually sitting all the time. So I'm worried about my cholesterol levels as well. I should get checked. So you need to be talking about sitting one, someone who sits a lot. Occupation, what you do for living. So are you sitting most of the time? Are you doing the exercises? Exercises stabilize a lot. So any stress, and again, remember all the stress in job, at home can trigger the high blood pressure as well. Okay, so you need to ask that one as well. Again, thyroid is also be ruled out. So it hasn't mentioned the thyroid you need to be ruled out. So you will be doing physical examination to check the risk factors. So you need to be checking for face, which is moon phases, which again, which is suggest of Cushing syndrome. You need to check for the BMI. BMI will be high if it's a be suggesting of cholesterol. And again, we review the blood pressure while you talking to, because we have recorded two blood pressure while the patient was sitting. By the way, this question will be giving you two settings of blood pressure has been recorded past, and the question will be long in this particular case. They will be giving you a whole story. They will be telling you he came in the past, the blood pressure was this. He came again, the blood pressure was this. This time he come, his the blood pressure was this. Again, when you will be doing inside, you will again have to repeat the blood pressure. So make sure you repeat the blood pressure. Now, you will be asking also, because we're looking for primary hypertension cause any radiofemoral delay as well, because of transpositions of artery and coagulation, so they will be delay there. They might not be there. They're not giving primary hypertension. And then you need to ask plethora and the acne. Also, you can ask the xanthosma, same as the hypertension examination. So you will be asking that. Provided fundoscopy is very important in this. Very, very important. All the hypertension case, even a physical examination station, and headache, and yeah, which one else I had done? Headache, hypertension, renal, diabetes. If you don't do the fundoscopy, it's a key issue. I think you will lose the entire station. The things people do it, they don't realize what we're doing is wrong. Okay, please keep in mind. High blood pressure, you need to tie a knot or do something about this. You need to definitely, even though if you forget thyroid, it's okay. That doesn't shoot the blood pressure so high. It cause increased temperature and, like hypohypothyroidism could be changes of rhythm, but not the high blood pressure. So that's why it's not so relevant there. Fundoscopy is very, okay. Provided when you're in the eye, please check for the neck, the carotid and the thyroid. Carotid blue is again important. All the stroke examination or even cardiovascular maneuver. When I'm teaching CVS examination in the PE, so I always check your carotid. And again in PVD, we do check peripheral vascular disease. We also check carotid. Okay. no examination, anything with vascular, leave without carotid. This is an error if you do that. So heart, you will be seeing the crepitations for heart failure in the lungs as well as the heart sounds will be abnormal if at all being there. And abdominal mass. Now, abdominal mass, we're checking for a couple of things. Polycystic kidney disease, again, renal mass and stuff. Okay. How do you do that? You ask the examiner, I would like to see the ballotable kidney, first of all. You put the hand behind of the tummy and push the kidneys up, and then you feel the mass. And then you ask the examiner, do I feel the mass? And do I have any findings? And the bruit. If the kidneys are being enlarged, any problems being there, like renal artery stenosis, in that time, I never heard of renal artery stenosis brewing, to be honest, in my clinical setting. I heard in the book that you have to do it, but you do need to ask in physical examination renal artery stenosis brewing. It's must. The step of examination in this particular question is important. Plus, you do not finish your finding without doing PVD examination lower limb. Asking, can I feel the capillary fill time, dorsalis pedis only, pulses changes in the lower limb, like including dorsalis pedis, posterolalis tibial, and the popliteal and going to femoral. Okay, so you need to be asking. Again, we always ask this one. We don't leave it without that. And edema. When you will ask, urine dipstick, proteinuria or glucose could be present. Now, people with the high blood pressure can have edema. Okay, so don't get surprised. And that doesn't mean that when you diagnose clinically proteinuria being very, very high and nephrotic kidneys are involved, then only if it could be 3 plus. But usually it can be high 1 plus. So don't get surprised. But you need to seek for it. You need to seek for, do I have these two? Because remember, diabetes and high blood pressure comes as a brother and sister. They always go along. So we have to suspect both. Okay. So you will be ordering this of the investigation urine analysis. If it's not been done, you perform GFR, fluid bed examination, blood lipid in uric acid level, urine electrolyte, sodium and potassium, very important. Now, that is for primary. If it's all secondary, other investigation, you will be thinking of renal ultrasound. If you can't hear the renal bruit and if you're suspecting renal problem, and 24-hour renal renin, aldosterone, and cortisol level, if they're thinking of pheochromocytoma with secondary to the secondary causes. And that's it. You will be actually doing the investigation and explaining it. So these are the things you should be knowing, like hypertension, the silent killer, and what are the things you need to do, how regularly you need to check, what are the things the kidney, brains, eye, all of them are involved, can have an involvement. And 62%, why we're doing this? Because 82% people in a normal general population can have a high blood pressure. That's why we need to investigate thoroughly. Okay, many people every year die not because of accident, they die due to because of high blood pressure and the causes to it. Okay, because it can just like cardiac arrest can happen, MI can happen, and these problems are more common than the accident in Australia. Okay, so that's why we do it. So you need to say that other explanations of what are the causes essential, like just a hypertension is 90%. Secondary due to renal is 10 to 4% are common, which is glomerulonephritis, any other to do with the diabetic nephropathy. As I said, diabetes come along as a brother and sister, so you need to find out that. Cushing syndrome, Crohn's disease, cooptation aorta, and the drugs like such as anesthesia. If it's a female in the exam, if she's taking oral contraceptive pills, yes, she would have a highly likely chances of developing high blood pressure, even though she never started with the high blood pressure. Okay, again, pregnancy in a gestational hypertension, right? You all know the preeclampsia. In someone, I'm not sure about the people who are sitting here having a gynae knowledge. The lady who had repetitively, like let's say she had a three pregnancy, and in three pregnancies she had gestational hypertension. Very likely that lady will definitely have chronic hypertension in her life. Same as the diabetes, more than two event of gestational diabetes, more than two times she's been pregnant and she got the diabetes. Every time she got pregnant, she will definitely end up having a diabetes. You should be knowing this, okay? That just piece of information. I remember it when I was preparing for my exam. So repetitive episodes of that, it's not good. Okay. So what we need to do, we need to regulate the blood pressure. Okay. We need to control the blood pressure in order to avoid the complication. Normal, it should be less than 130, which is means range of systolic. and diastolic should be 90. So we say that your blood pressure should not go 140 by, okay. So that is that. So if it's 140 by 159, it's a mild. If it's going above 160 by 70, where is a borderline where you have to really get subherifine hemorrhage and other things, that is high, and severe is more than 180. So you need to control the blood pressure. Now we have a non-pharmacological treatment and pharmacological treatment. Remember SNAP approach: stop smoking, adequate nutrition, alcohol in standard alcohol drink, and physical activity. Same thing you talk about: diet, exercise, alcohol, and salt intake. So salt intake is must to be reduced. Those person who get diagnosed with this high blood pressure. I have noticed my students are not, not my student, basically the students before I have met. First time I see, they do not divide the management into three portion. And those who are attending first time, Dr. Rajat, you are going for exams soon. Keep a note, divide that treatment of management: conservative, medical, and specialist. You divide into that, or I say specialist or surgical. Okay. So conservative AMC is love to hear adequate exercise, reduce salt intake. You conservative, they want to hear in detail. Okay, everyone. Saria, you need to hear conservative. They love it. In all cases, we have conservative. And I think Camelia, she passed her exam. She was giving me her feedback. She was telling Dr. Rachlan, this is the way she remembered it, because I had divided myself. And I think Dr. Burpreet, who is working at the moment, he divided the same way. And that is the key of success. You divide into three portions: conservative, medical, surgical. Let's say if you forget how to explain conservative, medical, and surgical or specialist, at least you give examiner an idea of what you're going to do. Okay. So conservative management is that we are non-pharmacological. We're going to manage you by avoiding the risk factors. Okay. These cases are not hard to handle. If these cases are not hard to handle, trust me, this one has to talk about other nonsense stuff. It's like, reading pamphlet. You going, instead of giving reading material, like, some people candidates are like, I did everything and I failed. The thing is that you didn't do everything. You need to explain your conservative more, especially internal level, because this is internal level exam. So stop smoking, reduce the stress. If you are actually working a lot, I'll give you time off. I'll give you certificate. So you take a time off. Okay. And the goal is to keep the blood pressure this. You need to tell the goal. It has to be less than 140 by 90. Those who can't remember so many number in the table, that's for your reading. But having said that, you need to be having a blood pressure. Systolic 140, diastolic, sorry, 90. And then if it doesn't control, it is not. So our aim to be making that balance of blood pressure by giving you medicine. We have to have add another medications: ACE inhibitor, beta blocker. Now there are the certain indication why people are looking for renal artery stenosis. I think if you have a bilateral renal artery stenosis, you cannot be giving ACE inhibitor. So you need to be worried about that. So that's why you will investigate before you give anything. Otherwise, ACE inhibitor is universally acceptable. Okay. So is thiazide diuretics would have a contraindication somewhere. We have a good circular diagram. So you need to remember A, B, and C, D. So it's A will not go to D, and C will not go along with the B. Okay. But having said that, if you don't remember anything, you need to say that I will refer you to cardiologist, you as a specialist. So say conservative, medical, and surgical. So I will refer you to specialist. He will be starting with your ACE inhibitor if there is no contraindication being involved. Okay, there are drugs which control by renal pressure. So we control the blood pressure from the kidneys as well. And we will be calling for hypertension monitoring regularly. And that only thing is that we need to make sure there is no high blood pressure. Blood pressure being down is also dangerous. Blood pressure being high also dangerous. So you need to be talking about fluctuation. We don't want that. Okay. Whereas a pheochromocytoma, usually it's actually relieved by operation. So we need to be talking about it if we find in the investigation. So we will investigate. We will give him at this time antihypertensive to rule down. But meanwhile, we will be avoiding through the factors, also risk factors being avoided, as well as we're going to do medical treatment and specialist review. Right. Clear? Any question? Any question? Any stress? Who is developing hypertension now? We need to know that. Any stress? Any trouble? I'm not. I don't see. What do you call? I don't see Vimlesh online. He was actually giving me call in the morning, like Dr. Rachna. Like what happened? And I was sleeping, half asleep. I was like, okay, you add me on this one in Messenger. Okay, next question. Psychiatry. So we had this one very famous case, King case. The word called King. I have heard two feedbacks actually on this one. One, I was keep on hearing when I was preparing for exam. The guy will stand up and walk around and come back in the room if he say King. Okay. In the actual big time, this time they did, but my friend she went for this exam, Prema, she passed her exam by the way. She's applying as a GP. I don't know. She passed recently, and then she told me that what her presentation was, the guy was sitting there and he was sound like more depressed. So she diagnosed her OCD by asking question of a thought process question. But having said that, not necessary that person will stand up and start walking. Okay, you need to be very watchful about that. Not necessary that will be happening. Okay, so don't get misdiagnosed. What is happening wrong? Okay, nowadays I have seen OCD video on OCD presentation, and the history taking is coming very surprising. Even my exam, I had OCD video, and then at the time, it always says that university performance is going down. Professor brought this up. Okay, so how to approach if he is walking inside the room, and how to approach he's not walking. Okay, what are the questions? So I'll give you both feedback. Okay, I know that it's coming in a two format. If it's at all, you need to take a history taking. All right. If at all you're watching a video, that's a different story. There is no walking video in OCD, so they will be describing a thought process being lost. Right. Having said that, 5th of September we had OCD video MSc. I might write down the transcript after talking to my student Ikra and Remia properly, because when they came out of the exam, they were in the acute psychosis, talking shingle as a linear rash, and they said one said cholecystitis to cholangitis. So I was like, the mental state of mind is all over the place. Ikra gave me a case of enalapril now. She gave me in the morning. Earlier she was not in a state of mind to give me that. It happens. It's natural. I can't force my student give me your feedback immediately. So guys, I'm sorry I did not include those cases because I don't want to deliver something wrong to you as well, and you go and do a mistake. So I got the proper feedback. So I'll give you Enapril and OCD video case on Monday. I can promise you that because I got the history now. But at that time, she was not in a state of mind to tell me anything, and she was even whatever she was telling, I was changing my slides. And I was like, what the hell? What she gave me? Was it a linear rash? What is this thing? And that's why I had to do it two times editing on my slides as well. She gave me all over the things. Okay. In this case, this time was a king case. Let's come in back to OCD. That case was also video OCD. I'll give you that. If I find the video, I'll give you the video as well. I have no issues with that. Okay. We can those who are going for exam, we can practice MSc. Oh, because I want you to actually have a hand on to the OCD videos as well. So, university student. University student means lack of focus. So what is making lack of focus? It is either personal issue, either thought process, or it could be a problem with his thought process, or taking drugs. So university student cases in the AMC are psychosis. I got psychosis in my exam. One case is king. One case is that my partner is cheating and he's sleeping around. And when you ask her when you and your partner broke up 7 years ago, and how come he's cheating now? So basically, that's a thought process problem. So again, you need to be talking about that. Again, The question which came on 5th of September, that guy had a poor university performance. I don't know why university performance goes down. And he was like saying in the video session, video MSc, he was talking about mom is sleeping with other guy. And he keep on imagining they were having sex in the video MSc. Okay. So I have to give you those transcripts. So I'll give you that one. Okay. On Monday, I'll give you, promise to you that, because I need some time to talk to them. They are out of their mind at the moment. Okay. And this one, again, the case of King case, and this one you have to perform MSc. He would be in a normal actual case. He would be, as soon as you use the word king, he will walk around in the room. He will take one turn and he will come back. Now, don't consider that as a disturbed patient. What should be the position of a doctor, you as an interviewer? There are people I have heard, if you have these cases in the mania and all, they start walking with the patient. Don't ever do that. Ever do that. There is the protocol to be there. What you do, you move your chair in the center of the room and keep on like moving your direction on the chair by sitting and asking question, but don't stand and start walking. Let him walk. Come and ask him to sit down for like, okay. If he doesn't sit down, don't worry about it. There are cases like such as delirium and disturbed patient. You do not start restraining it unless and until patient is disturbed and touching. So don't start doing that activity as well. Okay. There are people who are doing it, they're losing the station for nothing. This case is easy to do. This one as well. Very. I have actually got feedback from one old gentleman. He got a retest and he was frustrated. He got pen and he failed his retest. Then again, he gave full exam. Then he got the retest. And every time he went for exam, he always got the king case. He was telling me, and in the king case, it always hard to manage. First time he passed the retest. In the past, first time he had passed the king case, and second time he failed the king case. So he was asking me what I went wrong. So let's talk about that. First, ensure the confidentiality. All the psychiatry session I have spoken about, I've been telling you, ensure detailed confidentiality in this case. They will listen to you. If you do not do it, they will not listen to you. Say that whatever we're going to talk today, John, it's going to be confidential between you and me. And unless and until there is an issue, any concern, any harm, or anything to notify the department. These are the 3-4 things you need to make sure that examiner is also hearing that. So loud and clear. And even though if you have to spend 1 minute of time ensuring confidentiality, please do that. Otherwise, you won't get a history from the patient itself. So could you describe me about the thought? So what this guy will do, he will actually say word, Doctor, as soon as I see the word king, I then he will walk, take a circle on the room, come back and sit down. I feel anxious. I have to take a round and come back. Okay. So you will be, instead of actually jumping from the king, you will ask him, what are you doing exactly? Is that you were preparing for exam, or you preparing for assignment? What is your major? You ask, because you need to ask why he's actually worried about the king word anyway. Don't repeat the word over and over again. More you will repeat the word, more he will turn around, go back, come back, and sit down. Okay. So you try to distract him from that thought question, but especially avoiding the king question. Now, Prema told me about this case. He was depressed. I don't know why he was depressed. He was asking me, and I was like, the OCD people, they are not very happy about their thought process. They come with thoughts of depression along with it. And again, AMC examiners are looking for this thing. They are looking for whether you assess their comorbidity. The cases they're defining, the comorbidity in OCD, depression is very common. So you have to evaluate that. Okay. If the person was sitting there not moving with the word of king, she told me that as soon as she said the king word, he didn't actually turn around and come back. So she was confused. Like the presentation is coming up like this. How come he was so depressed? Because he would be tired of doing that circles coming back and forth, coming back and forth. So all you have to go and ask, are you doing history major? Are you writing novel? Are you actually reading other things? So he will talk about this. And when since how long this has been happening, he will be telling it's been happening quite some time, like from past 3 months or 6 months. Okay, duration is important. If it's happening more than 6 months, you should be considering something, overlapping depression symptoms. And when you start having this condition, is it like first time, or is it like anything else has happened? So now you need to have a very good thought questions. OCD is a thought question. So first, you need to ask yourself, it would be best idea for those who are going for exams is actually put the thought question in the beginning. Do you get recurring? This